So the focus of this year's conference is on emergencies, and so the emergency that I deal with most frequently is postpartum hemorrhage. And most of you know that immediate postpartum hemorrhage, defined as hemorrhage within the first 24 hours of delivery, happens in about 5% of all deliveries. And the definition is pretty arbitrary because it's defined as a greater than 500 milliliter blood loss at a vaginal delivery or greater than a liter blood loss at cesarean section. But we're notoriously very poor at estimating blood loss with these procedures. And so lots of other definitions have been proposed, but this is what we continue to use for the present time. It's kind of, I think for most people, the definition is not so much based on blood loss, but you know it when you see it. And the causes are pretty, there's a pretty short list, the 4 T's. By a way, the most common cause of postpartum hemorrhage is uterine atony. But postpartum hemorrhage can occur from extensive lacerations or general shock trauma, that's the second T, retained products of conception, or the third T, which is tissue, and abnormalities of coagulation, or the last T, thrombin. An initial evaluation of postpartum hemorrhage for most obstetricians can take place in less than a minute. The important thing to remember is that you should get more hands in there and make sure that you call for additional nursing and support staff and that you notify anesthesia so that you have the assistance that you need with what needs to be done for the patient. You should obtain or hopefully maintain, because you already have adequate IV access. And depending on the degree of hemorrhage, you may consider drawing some labs immediately, not for assessment of blood loss, but for assessment of coagulation. And we'll talk about this a little bit more later in the talk, but just simply drawing a red top tube, depending on the amount of blood loss that's happened already, drawing a red top tube and letting it sit on the patient's bedside for the next 8 to 10 minutes to see whether it clots or not is a very good bedside assessment, and will give you an assessment of what that patient's fibrinogen level is in about 8 to 10 minutes, whereas the lab will probably take 30 to 45 on a good day. If the red top tube sitting at the patient's bedside doesn't clot within 10 minutes, you know her fibrinogen is less than 150. And that can help you to direct your therapy. You probably, especially if your red top tube doesn't clot, you also want to have another red top tube that you've sent down to the lab to get blood products. A Foley catheter is often should be placed to decompress the bladder, allow for better assessment of the uterus and monitoring of urine output, and then a quick exam to evaluate uterine tone, potentially a manual uterine exploration and search for lacerations, particularly if the uterine tone is normal. And this could take place very quickly. Before you get there, we wonder if it can be prevented. Well, the World Health Organization recommends that active management of the third stage of labor can prevent postpartum hemorrhage, not in all cases, but it certainly reduces the likelihood that it will happen. And their guidelines are very broad. They do recommend use of uterotonics. How that's administered or what uterotonics are given, we'll talk about later on, but this is standard of care in all U.S. hospitals, controlled cord traction and uterine massage. And this does significantly reduce the risk of postpartum hemorrhage. But once you're there, how should you treat it? Well, to a certain degree, the treatment depends on the cause. And so that initial assessment that identifies your cause of postpartum hemorrhage should also guide your treatment. Obviously, placental tissue that remains in the uterus should be removed. Lacerations should be repaired because treating uterine tone isn't going to help blood loss from lacerations. And coagulopathy should be assessed. Now, we've talked about a quick bedside test, but if you're not in dire straits, and you should consider testing these women for coagulopathy by getting a CBC, PT, PTT, and fibrinogen. And again, this should be guided by exactly how large the hemorrhage should be. And then the coagulopathy should be treated promptly. Most of my talk is going to be based on addressing the most common cause of postpartum hemorrhage, which is uterine atony, and talking about medical and surgical treatments for this. But I'm going to take a quick aside and talk about treatment of coagulopathy and hemorrhage in general. In women who've had a massive postpartum hemorrhage where you've estimated they've lost, more than 2 liters of blood loss, you really ought to think about getting blood products available immediately. And our combat experience in Iraq and Afghanistan would suggest that replacement of massive blood product replacement and massive hemorrhage should be done a little bit differently than what we were trained to do in medical school or residency. And their protocols have shown that using a 1-to-1 ratio of packed cells to FFP resulted in much better control of bleeding and better hemostasis. And this because we don't use whole blood anymore, and these patients are losing their clotting factors in addition to their packed cells, this is what currently we use at the university for cases of massive hemorrhage. It's a 1-to-1 ratio of packed cells to FFP based on the Iraqi and Afghanistan experience. This is also what's used in most emergency rooms now for blood product replacement and massive hemorrhage, and it does seem to improve outcomes. Make sure that you also think about using cryoprecipitate in patients who have a fibrinogen of less than 150. And probably the most important thing here as you start to pour blood products back into your patient is that you've got to remember to keep the patient warm. It's really difficult to get someone to stop bleeding once they become hypothermic. So the main crux of the talk is to talk about treatment of uterine atony, which is the most common cause of postpartum hemorrhage. For standard of care in all U.S. hospitals and in most developed countries around the world is oxytocin, and this has been studied extensively, and it remains the most effective first-line strategy. It can be given, most of the time this is given prophylactically, IV or IM. The usual doses that are given are 10 units IM or 10 to 20 units IV, diluted in 1,000 milliliters of crystalloid, and this is just run in either with delivery of the anterior shoulder or at the time that the placenta is delivered. And whether you choose to give it a little early or to give it when the placenta actually comes out is fairly controversial. Some studies have shown that there's decreased blood loss when it's given at the time of delivery of the anterior shoulder, but other studies have not substantiated that. The dose is also somewhat variable, and up to 80 units in a liter of crystalloid has been used safely. You should use caution in giving large boluses, especially if you're giving higher doses, because oxytocin can cause profound hypotension. Well, what are other things that can be used? What if you don't have IV access or your hospital is short on oxytocin? The ergot alkaloids in the U.S., Methergin is the most commonly used. These are equivalent to oxytocin as far as prevention and treatment of postpartum hemorrhage as a first-line therapy, but they have more side effects. And they generally cause hypertension, nausea and vomiting, headache, and for these reasons, and also because of storage difficulties, ergotamines have to be stored under specific conditions. They have to be protected from exposure to light, and because of these issues, they're not used as commonly in the United States except as adjuncts to oxytocin. Prostaglandin F2 alpha, or Hemabate as it's marketed in the U.S., can also be used to augment oxytocin. It's not as effective as a first-line therapy, and it's very expensive, and again has a lot of side effects, fever, abdominal pain, and a lot of diarrhea. So what's been used more commonly in recent years is prostaglandin E1, which is misoprostol, which is really cheap. It doesn't have to be stored in any particular way. It comes in a tablet form. You can leave it out on the counter for weeks at a time and it will still be effective. It is not as effective as oxytocin in prevention of postpartum hemorrhage, so it's been studied, compared it to oxytocin for initial prophylaxis, and is not as effective. But it is very effective when it is given as an adjunct to oxytocin for somebody who is having a postpartum hemorrhage. The other advantage to misoprostol is that it can be given orally, sublingually, vaginally, or rectally. Rectal administration is preferred because it has been shown with this route to have a longer duration of action, and the side effect profile is reduced. The dose is anywhere from 600 to 1,000 micrograms, and side effects are present but less common and are usually nausea and vomiting, shivering, or fever, typical prostaglandin side effects. But this is a very effective drug, and in combination with oxytocin for women who are having a postpartum hemorrhage, it's over 90% effective in stopping bleeding. So what do you do when you've run through all of those medical management, the medications, and you still have ongoing bleeding and uterine atony? What's been used more frequently in recent years are tamponade devices. Tamponade has been used for decades as a treatment for postpartum hemorrhage, but what it used to consist of is taking some surgical gauze and soaking it in thrombin and then packing it in the uterus. And as you can imagine, the quality of the packing is highly variable based on the patient and the anesthesia and the experience of the provider. And it's certainly not an ideal way to compress the uterine lining and stop bleeding. What has been used more frequently in recent years is this Bacri balloon, and this is cheap, widely available now. It is placed inside the uterine cavity and stops bleeding by a method that we all know really well from first aid, which is direct pressure. It can be filled with up to 500 milliliters of sterile saline or water. Most authorities would recommend that patients are treated with broad-spectrum antibiotics while the balloon is in place, and it's generally left in place for 18 to 24 hours. There are no randomized controlled trials of treatment with the Bacri balloon versus other things, because there really are not a whole lot of women who have hemorrhage to the degree that they fail all of their medical management and get to these type of therapy. And the largest case series that's been reported, which is 162 cases, and these were women who had already failed medical management of postpartum hemorrhage. The placement of a Bacri balloon was effective in 84% of those cases, which is, really successful for a device that costs a couple of dollars and takes about a minute to put in. And this is something that I think has really saved a lot of uteruses over the course of the past few years. The other techniques that are conservative and surgical are a little bit more invasive than just placing a Bacri balloon. A Lens Suture is an external compressive technique which uses typically a number 1 chromic suture placed. And it's more commonly done at the time of C-section, but can also be done in patients who have had a vaginal delivery. And the stitch is placed horizontally across the lower uterine segment, and then over the top of the uterus, horizontally again across the lower uterine segment on the posterior aspect of the uterus, and then loops over back around front and is tied in the lower uterine segment. This essentially folds the uterus up and provides external compression as treatment for atony. It has been very effective in case series, but the downside to using a Lens Suture is that we really have no idea how this affects future reproduction and how much it compromises blood flow to the uterus. There are cases reported of uterine necrosis in patients who have had Lens Sutures placed, but if you are faced with a woman who's having a life-threatening hemorrhage and she has not responded to your medical management or your Bacri balloon, it's probably worth taking the risk. Alternatively, you could consider, if you have a hospital with an interventional radiologist and you can get staff in fairly quickly, uterine artery embolization has been used also in case series for women with postpartum hemorrhage that's refractory to medical and conservative surgical treatment. Again, the downside, in the case series that have been reported, this is also very effective however, with unknown effects on any future pregnancies. So you may be saving their uterus only for them to have a really complicated pregnancy in the future. So finally, something that's also gotten a lot of attention recently, primarily because of our surgical experience in combat, is recombinant factor 7A. And this has been used also in women who have had refractory postpartum hemorrhage and appears to be a very effective therapy. This is extremely expensive and not as widely available, but it has been used after failure of medical and conservative surgical techniques as an alternative to proceeding with hysterectomy. Most of the time, by the time women get to this point, they are coagulopathic, they have metabolic abnormalities, they may be acidemic, and so those are things that have to be corrected before this can be given because it won't work. But if you've corrected acidosis, if you've kept your patient warm, if you've replaced their fibrinogen with cryoprecipitate, and you've addressed their metabolic abnormalities, which is something that generally takes place ongoing as you're doing all this other treatment for postpartum hemorrhage, then before you start your hysterectomy, you may consider giving recombinant factor 7A. The recommended dose is 90 micrograms per kilogram, and it's infused over 3 to 5 minutes. What this does, activated 7A works at the site of bleeding. And so where the bleeding is, you will have tissue factor exposed on vessels. Recombinant factor 7A will bind to tissue factor and initiate the clotting cascade at the site of bleeding. And so it works exactly where you need it. The concern has been is that are we placing these patients at risk for thrombosis in other places? And that's been primarily a theoretical concern. There have been cases of thrombosis, deep venous thrombosis, and pulmonary embolus reported as a consequence of using factor 7A. I think in the patients that are getting factor 7A, I think it's very difficult to attribute those events solely to factor 7A because by the time they are sick enough to get this medication, they have extensive tissue damage and damage from shock. And I think it's difficult to attribute any thrombosis that may happen just to 7A. If the patient doesn't respond within 20 minutes, a second dose can be given. There are only case series reported, again, of recombinant factor 7A, and these are worldwide. There is a meta-analysis that was published within the past year that collected all of these and analyzed them together, and the total number of cases that were reported were 272. And use of recombinant factor 7A in these women averted hysterectomy 85% of the time. Of course, I don't have a slide on the last treatment, which is hysterectomy. Any obstetricians in the crowd who have been there would, I bet almost unequivocally, choose not to be there again if there was any other alternative, because it is a peripartum hysterectomy, particularly in the case of active hemorrhage, is a fairly harrowing experience, mainly for the patient, but also for the doctor. And so using these conservative therapies to try to avert going to the operating room for that type of procedure is certainly worth it. It improves patient outcomes. And that's the end of my talk. If you have any questions, I'd be happy to take them. Yes. Right. So the O'Leary stitch or hypogastric artery ligation have been done in, again, there are case series showing that if for the largest case series looking at O'Leary sutures, which is just ligation of the uterine artery, is from actually O'Leary himself and his institution. And in his hands, it's a very successful procedure and averts hysterectomy and stops bleeding in postpartum hemorrhage. When this has been replicated by other investigators, it has not been shown to be nearly as effective. And this is probably because, or the speculation is that in the O'Leary series, the stitch is actually placed much lower than where most obstetricians would feel comfortable placing it. And with an O'Leary stitch, there's also a risk of ureteral ligation. And so most, when this has been studied in the general population of obstetricians, it hasn't been all that effective. A hypogastric artery ligation, if you've ever been in that situation, is very difficult to perform once you have a pelvis filled with blood and filled with a large uterus. And again, in the case series that have been reported, has not been shown to be as effective as some of these other conservative surgical therapies. All right. Thank you.
Well, that ends our 4 for this morning. We're on break. I think you're really going to enjoy Dr. Lex. He starts in half an hour. We'll be starting on the other side of the wall, as you recall from yesterday. So please go out, enjoy the exhibits, and let's see you in half an hour.